a previous webinar in the series. And you can see and find these on this web page here that you see on your screen. All can be linked from there. If you are interested in CEUs, there is a processing fee of $20. You can get CEUs from ACNM or MEEC, both of whom have approved all of the webinars in the series for CEUs. And for that information, you just email equitymidwifery@gmail.com. Also, for those of you who would like to engage on this topic in a different format, please join our next Equity Strategy and Collaboration call on Friday, January 19th at 2 p.m. Eastern Time. And finally, we would like to request your feedback at the end of the webinar. I will be posting and sending you a very brief survey, only 1 page long with 4 questions, and we would greatly appreciate your evaluation of the webinar and your suggestions for future topics for speakers, especially because next year's schedule has not yet been determined. In just one moment, we will begin recording the webinar. So here we go. Welcome again, everyone. The title of today's presentation is Infusing Equity and Diversity into Clinical Teaching. CEUs are available for this webinar, including for watching the recording. Interested persons can email equitymidwifery@gmail.com for more information. And now, without any further ado, I would like to introduce our presenter who has been published in the Journal of Midwifery and Women's Health on this topic. Karline Wilson-Mitchell has been practicing midwifery since 1992 and is currently a faculty member at Ryerson University in Canada. She has practiced in Florida, North Carolina, Georgia, and Ontario, both in large hospital-run midwifery practices and private clinic-based practices. Karline has a deep interest in international health and health policy and works tirelessly in pursuit of health equity while also promoting equity in midwifery education and training. And now, I will turn over the screen to Karline.
Thank you so much, Kristen, for such a welcome and inviting intro. And I guess I'm going to be sharing my screen now after you stop sharing my bio. Is that correct? I'm so pleased to be with everyone today, and I'm so pleased that all of you are as interested as you are in this very important topic. It's very near and dear to my heart, and I was just sharing with some of the, well, I guess that's the interesting thing. When you're sharing your screen, you have to find out where everything is. It's all new and in a different form. Wonderful. So I was just sharing with those who are participating just prior to the start of our webinar that we are very fortunate here in North America that some of the childbirth rights and also the responsibilities are not new to us in maternal newborn health care, that in fact we've had hard-won human rights and childbirth rights since the women's movement and certainly the consumer movement here in North America since the 60s, 70s, 80s, and now we're in the 21st century, and we're now at the stage where we're infusing this into our curriculum in a greater way, in a more critical and thoughtful way. Whereas in South Sudan, where I do consultancy work, they're just beginning to see the value of this and incorporating it into respectful maternity care. So they're looking to us to lead the way, and always we need more hands on board who want to help us write grants and help us to be able to build capacity in the global South. So I'm so glad to be here, and this is not work, this is fun for me. So let's go ahead and start. You'll notice I like to use a lot of photos and art because a picture speaks 1,000 words, and because I'm from the African diaspora and a story means something to me. The story or the proverb tells more than the words. But because I, was privileged to be educated in North America, I also know the positivist and sort of logical, systematic, so-called way of making an argument for something. So I'm going to be sharing with you a lot of evidence-based principles and strategies for being a provider that is thoughtful, caring, sensitive, not perfect by any means, but someone who is providing respectful care, basically. I was funded to be able to help with a group of my colleagues here at Ryerson University and midwives practicing in the community in a diversity equity project that we had for really building capacity for our preceptors who really teach 75% of the content of our course. And as many of you who've maybe done a community-based education program know how important and vital there needs to be harmonization between what the preceptor is teaching and what the faculty in the school are teaching. So we wanted to make sure that even our way of approaching dilemmas was equity-based. So we developed this, we got a grant. It was from our Learning Teaching Office, and we were able to publish in the November issue, a supplemental issue in the Journal of Midwifery and Women's Health last year. So our learning objectives today are to summarize the research, discuss insights, approaches to handling difficult situations, particularly those in which the preceptor, student, or client become uncomfortable. Techniques for engaging students in experiential learning that respects cultural sensitivity and diversity, and provide a culturally safe space for our students to learn as well as our clients to be cared for. The challenge of balancing those two rights, and then strategies for how we treat our clients equitably, no matter how they self-identify in terms of their bodies, their race, or whatever kinds of other labels that are somehow socially prescribed on us. So this is a joke. And as I'm drinking my Himalayan, or not Himalayan tea, this is my Mount Kilimanjaro coffee. I'll just let the picture speak. So faculty, supervisors in the field, student advocacy groups, all of these forces are there telling us that we need to infuse diversity into our field training, whether it's a social worker student, nutrition student, business student, laboratory or engineering student, midwifery student. And so this has become one of the basic core foundational tenets, especially at my school, where social justice is really a center point of our curriculum. The governing bodies that now govern us, our boards, our licensing and regulators are requiring this. Certainly the consumer movement is requiring it. Our students are giving us feedback that they don't always feel as though their learning spaces are safe. And as I mentioned before, because in the field, it's these professionals that are training us. So that's what was the engine that sort of pushed this. And so all of us who are here, I consider experts or field instructors because we've had students. Now, while I'm doing the sharing in this large mode, I guess I can't really see hands. So I'm going to have to have your voices tell me that you need me to stop. It's unfortunate by sharing my entire screen or making this PowerPoint go into fill the whole screen, I can't see your hands or your chat, but please, Kristen or someone can stop me if you need to.
I will do that, Karline. I'll let you know.
That's wonderful. So we'll be using terms interchangeably, but whenever it says a field instructor, it means a preceptor to us. I developed these slides for a very mixed group originally in our faculty conference, but you can see that almost everybody's on board. We're not alone when it comes to wanting to learn how to teach diversity to whoever is in charge of our students and their placements. And basically all of us need diversity training, no matter what kind of work we do, whatever sphere we're in, wherever, there are structural discriminations, a systemic kind of discrimination going on. We are going to have to help our students match the theory they're learning in the classroom with the real world. So we're challenged to produce global-minded, socially responsible graduates who are really global citizens, and they can, meet the requirements of a diverse workplace and a diverse consumer. So we're hearing it from the top down, from our presidents, from the industries that we work in, that we need to graduate these globally savvy students. But the educators themselves have not always been trained. And the educators themselves are sometimes working against difference, because sometimes the educator is from a marginalized group, or the student is from a marginalized group. The client might be from a marginalized group. So there's working across difference in so many dimensions multiplied. And sometimes those differences imply, if you're looking at epigenetics, life course theory, some kind of oppression and sequelae, or complications because of that, ways of dealing with stress differently because of that. So that's why we're trying to have a safe space right now in this webinar where we can talk about this and just be vulnerable. I can share with you some of the bloopers I've made, even up until a couple of weeks ago. I always, in every situation, need to ask and never assume, because intersectionality is at play, and what is respectful to one person that's identified within a same cultural group might be different for someone else. So we have to assess each situation and be humble. Professional humility goes a long way. So there's some overarching guidelines and policies. Not everyone follows them, but they're there, our governmental policies. So the future health of the nation will be determined to a large extent by how effectively we work with communities to eliminate health disparities amongst these populations who experience a disproportionate burden of disease, disability, and death. Health disparities or inequities are differences in health outcomes that are avoidable, unfair, and systemically related to social inequality and disadvantage. That was from Margaret Whitehead, the very famous sociologist, and it's also been adopted by one of the public health departments in the local Greater Toronto area here. And the OMHH has said that we want to promote access to high quality preventive health care. And we know that if we are culturally insensitive, if we are disrespectful, if we are using, really, it's systemic violence, structural violence, we will prevent people. We will be barring their access. They will not want to utilize our facilities. The road to learning about diversity and equity, and also the history behind why this is important. There are a lot of things that are sort of the philosophical underpinnings and the movements in our communities that have sort of heightened this and our awareness to this. So in 2015, the World Health Organization developed a charter of sexual reproductive health rights, the human rights codes that are in each of our cities, ideas about accessibility and rights for the disabled, and then just looking at all of the different diversities in our census, in our annual census, our regulating bodies, shifting priorities within the American College of Nurse Midwives, and I think the CPMs also have some of the same diversity, equity, inclusion kinds of changes. Some of the population changes, for example, poor Blacks in the rural area have 2 to 3 times as much premature mortality. Cervical cancer and poverty seem to be linked. LGBTQ, and now I should have probably updated my slide because there's now two-spirited as well, and questioning. There's an increased suicide, social stressors are there. there's definitely disparity in these communities, in the Black community in particular, because a racialized community where it's a visible minority, heart disease, stroke, hypertension, obesity, Black women had the largest infant mortality rate amongst their babies and preterm weight, 1.5 times the rate of white infants. So all of this is pushing us to say, you know, our students themselves are saying we need to do something. And in fact, students have developed their own version of the UN, and they meet on a yearly basis for their hubs. So this just, you know, explains the United States in a nutshell in terms of the varying infant mortality rates. And as midwives, this concerns us because that means that in some of our populations, the infant mortality rate is even higher than it is in some of the global south. And so there's disparity within the country, as well as if you're looking across the board from the global south compared to the global north. But there's a spread right within the one country. And in Canada, unfortunately, it has not been the practice to measure race, and so we don't even know in our Black population what these numbers are. That's one of the goals that I have for some of the work that I'm doing with databases. But certainly we can see in terms of preterm births, it's the same sort of picture. So thoughts for us to consider in our institutions. Do we recognize all of the intersections and therefore intersecting oppressions that someone can experience by the virtue of their membership? So even their immigration status, their accent, all of those things can cause them to experience oppression and for them to have special needs. And for us to be able to even ask more questions or do more research to find out currently what are the issues and priorities and ways of being respectful. We need to integrate equity, diversity, and inclusion as our core values in the mission of our organizations where we work and provide care, as well as in our educational facilities. We need to measure the acquisition of goals of quality improvement by the outcomes. So are we seeing improvement in some of those health indices I talked about? Are we seeing more of our students of color or LGBTQ community students succeeding and actually excelling? Or are we seeing many of them not being successful in our programs? Is it the student or is it our curriculum? What's wrong? What needs to change? How do we measure, quality? Is it how we are intentionally inclusive? How intentional are we? And critical self-reflection. Have I been building a tradition of inclusion or have I simply been focusing on demographics? Am I colorblind? Well, I would suggest to you that color blindness or treating everybody as though they were equal is not respectful. That in fact, we do need to pay attention to differences. And we don't need to treat people equally, but treat them according to their need or equitably. And are we able to adapt to the cultural mosaic in the workplace? Adaptation can sometimes be painful, until we get to an equilibrium and feel comfortable again, but it's lifelong learning. So just a few common definitions to make sure we're on the same playing field. Cultural safety is providing interaction, service, or partnership in a way that respects difference and provides a safe space to access services, opportunities, or resources. So that could be for the client or for our students or for our faculty, in the place where they work. How to achieve a partnership in an uneven playing field. I'm going to share my my desktop and share another really great photograph that I saw, or drawing that I saw, that really shows the difference between equality and equity well, I think, that shows we have an uneven playing field. And really, we shouldn't feel guilty. I am very privileged because unlike my sisters in Jamaica, my fellow Jamaicans, they may not have had the opportunity for education. I was fortunate to have been born in a family where my parents were able to struggle and achieve education for me, and that I live in a country where there's running water and electricity, and my sisters in South Sudan have a curfew and they had to cut our meeting short this morning so that they could get home and get the driver home before the curfew and the civil unrest and some of the other challenges that they have. And they don't have a fax machine, and not every school has, electricity or a Wi-Fi. So I can use my privilege to leverage opportunity, voice, and advocacy for my fellow midwives in other parts of the world, or for students who have a disadvantage because of where they are placed or where they're positioned in terms of status and so on. What are my ways of knowing and connecting? What are the other person's ways of knowing and connecting? And that means I'm doing more listening than I'm doing speaking. I am really there to learn from them, listen to them, what makes them tick, what's been their history, what do they need from me? So this workshop really is a guide. This webinar today is like a guide, but you're going to go on to perhaps think of other stories and scenarios and talk amongst your colleagues at work and with your students, and even maybe make up scenarios that you'll use in your teaching. You know, we use problem-based learning a lot, or case-based learning, and incorporate things all the time from real life, disguised, names disguised, and situations disguised so no one can see themselves, you know, looking back and on the screen. But certainly real life informs our future, you know, scenarios and things that can really help students learn. So what I'm going to share with you is the content of various scenarios I've used either with midwives or with mixed audiences. And Anthony Muhammad was a diversity and equity officer who helped me with these slides a long time ago. I've since modified them quite a bit, but I wanted to get an expert in the field since this is not my field. I'm not an anthropologist or a sociologist. I'm a clinical midwife, and I wanted to make sure that I had someone who was keeping abreast of all the current evidence about equity. So he was very helpful. So the term culture is going to mean the word group. It doesn't necessarily mean ethnicity. It is just a self-defined group that has common characteristics that gives them some solidarity and identity. So it could be a group of midwives who have CPM training. That's a cultural group, versus a group of midwives who have nurse midwifery training. That's a cultural group. Or it could be a South Sudanese, you know, group of student midwives, or it could be, you know, a group of midwives from New York City, you know, who are learning midwifery. Conceptually, services are delivered by and for people who reflect the demographic makeup of target communities. So that's a concept that we want to consider, because the research tells us that if care is delivered by someone who the community accepts as part of them, it seems to help. They request that, they like that. However, it's not always possible. So when someone is simply trying and making an effort and has done their homework and apologizes for making mistakes, that's okay. That's acceptable. And meaningful dialogue is important, you know, even if you cannot share group membership with someone to provide the care, it's important to be able to have meaningful dialogue. And then also be able to, you know, be aware of systemic and cultural barriers. One of my colleagues, Manavi Handa, here at Ryerson, says, you know, it's not basically having potlucks, but no power. We can go to a lot of potlucks where we learn how nice South Asian food is, or we learn how nice Korean food is. But if we're not able to somehow leave that sort of icebreaker to then go ahead and find out, how would I be respectful if I were helping a Korean mother grieve the loss of her baby that was born stillborn because of a cardiac defect? Or how will I be culturally aware if I'm hearing that one of the elders in my Native Indian or indigenous population wants to come in and do smudging during right after the birth? How will I be able to advocate for that? It's, you know, how will I be able to, it's not a fire, will I be able to help policies to change in my facility so that it won't set off all of the smoke alarms? So there are systemic barriers or cultural barriers that we need to be aware of. And, you know, cultural safety is an equity strategy. All of these things are ways of advocating. and promoting equity. And so we talked about what kinds of groups. It could be race, which is really a social construct. It's very arbitrary, used primarily for oppressive means or by governments who want to organize people for how services are allocated, but it's certainly not, there's no biological basis for it. We realize that, but we use it because it's the term that has funding out there. Ethnicity or racial background, age, sex, or biological makeup in terms of male, female, intersex, gender, which is much more fluid and self-identified, class in terms of socioeconomic class, ability, sexual orientation, religion. Can anybody think of any other groups that might be helpful for us to even highlight today? Other ways people identify? Maybe by the end, or maybe you'll write it in the chat. So the priority of our government is to decrease health disparities, address social determinants of health, and promote access to high quality preventive health care. And this is all based upon the social determinants of health. We know that some of those social determinants are not there, but could very well be, like immigration status, insurance status, whether you have insurance or not, and race. And many of them are interconnected and seem to determine, if health disparities exist. And certainly Vermelia Randall, Dr. Vermelia Randall in Ohio State has done a lot of work on health disparity and actually life course and epigenetics and how it predisposes you physiologically to certain stressors that you carry in your system. And then just all of the connecting pieces and the social determinants of health. I know this is a very busy slide, I apologize, but your social class, how it affects all these other things, in an ecological framework, all of these things affect inequalities. Health equity refers to the actions required to achieve similar or equal health outcomes among diverse populations. That's our goal. So, equality means the same treatment. And it's been very common, transcultural healthcare in the 1980s, but it was not good enough. It did not help us to to avoid these health disparities. Equity is fair treatment, recognizing that different people need different care or different types of interventions. Epidemiological fallacy. Many of my students are so afraid of doing this that they don't do anything. They're paralyzed with fear. So if I have a client who comes in and she's Black and she might be single and this is her first baby, I could look at the statistics and say that she has, maybe a 50% chance of having a preterm birth, even though she's well nourished and she is well educated and she has a high socioeconomic level. But simply, I could start treating her as though she's a walking time bomb rather than doing an individual assessment and on a regular basis asking her if she has signs and symptoms of preterm labor. So I have to do an individual assessment. I cannot attribute a population statistics from the epidemiological, big data that I have and then erroneously just label this person as a walking time bomb. And that's the problem with risk scores. Often our students don't know the difference between you're at risk for something or you actually have it. And they need to do individual assessments. Working across difference. Now, it's okay if there's discrimination when you're eating ice cream, but it's not okay to have discrimination when we are dealing with clients. So number one is involving the stereotype, treating every person in a particular group as though they're identical and sort of generalizing about that group, or often it's making negative statements about that group. There might be one person in our past who did something, usually negative, and we think everybody who is like that person will continue to do something negative. Two is a prejudgment, making a decision before even getting all the evidence. And we see this a lot in the school system. If you sample a lot of students, they will tell you that the prejudice started in preschool or, grade school. And even our clients will sometimes fail to utilize the system. They'll come at the last minute when they're in rip-roaring labor at 32 weeks. They didn't come previously because of the prejudice they had faced. And you know, discrimination operationalizes stereotyping and prejudice and places a value on choices. So you treat someone differently based on their membership in a group, and the implications, of course, can be dangerous, when it's a social context that we're talking about. I like to be discriminating about my ice cream because I like pistachio or I like rum and raisin. There's no ill effect to that, but certainly ill effect if I am going to separate people and one group of people has better services than the other. And when in our organizations, there's a systemic thing, it's just the way we do things around here. And, there's a certain policy that we have with good intentions, but that policy is excluding certain people from accessing. So if our library closes at 4 p.m. every day, but most of the students in a low socioeconomic level have to have part-time jobs after school, and they can't access the library after 4. They need a library that will open until 12 midnight, or they need some sort of online resource or online access to the library. That would be more equitable and would be less of a systemic discrimination. So these are the isms or types of discrimination, and certainly we can think of some more. Recently in Canada, we have been concerned about the increasing amount of Islamophobia, and everyone who is Muslim is being seen as high risk or a target, possibly someone who could be a terrorist. I mean, it's very sad. And we had some recent violence against members of the community praying in a mosque during their lunch hour. There were some very high-powered people there, Nobel Prize winners, professors, members of the government who were killed. Very unfortunate. So take-home questions and challenges. What are the actions that will be required to achieve similar or equal health services or outcomes among the diverse population I work with? So look at my particular group. What can I encourage in terms of social action in my student? What can we both do together to change a practice that we see as discriminatory? And it might not change overnight, in a day. It might be a long-term thing. Diversity doesn't guarantee excellence, but it's vital to providing a good foundation. And they'll try to master these skills in a changing environment. So it keeps changing. It is challenging, but we're there as a safety net. They at least can unpack their feelings and try to work out these dilemmas with our help. How do I approach dilemmas when an issue of racism, gender discrimination, class bias, ageism, ableism, homophobia, sexism, autism, transphobia, or anti-faith bias comes up? Will it become a crisis for me and the student, or an opportunity for both of us to learn? Where does my social power? That means the things that provide me with advantage. Where does my social power come from? Is it because of my age? I hold power because of that. My language, I sound as though I'm white, and that has some power and some privilege when I'm actually a person of color. My religion, the neighborhood I'm in, my exposure to international travel, so that I'm more savvy now and I know certain things. What can I do to actually, if you're looking from a feminist point of view, change that power differential a little bit when I'm working with someone who doesn't have those things? So we set up these training exercises, we got into small groups, and then the small groups came back and informed the bigger group. Each small group got a different scenario, but we're gonna, in our group today, just look at all the scenarios together and then just ask ourselves deep critical thinking questions as we go through each layer of the scenario. So how are we doing for time? I think, okay, we've had about 35 minutes, so we're doing okay. The first example, First of all, before I go through this example, I'm going to stop sharing for a moment so I can see everybody's hand and just get some feedback. I wish I could see all of your faces. I just see a screen that has a little person that says invite others. But are there any comments, anything that resonates with anyone from what I've said so far? Any questions?
Karline, one thing I think that is possible, while we give people a chance to drum up their questions, I think it's possible for you to share your screen, and then if you slide your mouse up to the top, I think you can hit chat and participant. You can hit the where it says chat, and then I think you can still share your screen and also see what comes in on the chat box as well. Why don't we try that? And then I can let you know that Eliza Spears, I believe you can unmute yourself if you'd like. She initially, I think, had a sort of question comment about wondering about if it's the demographic that the student lives in. And maybe you can clarify, Eliza, what you were thinking there.
Yeah, that's a good point. Could you clarify?
Yeah, go ahead. Try to unmute yourself. Do you know how to do that, Eliza?
Can you all hear me?
Yes, we hear you well.
Oh, good. I have a bit of a head cold, so I apologize for my scratchy voice. I was mostly just making a statement when you were discussing the ways that students who are in minorities might be treated, or and you had mentioned a couple ways that they may be discriminated against, and I was just making a statement that for me personally, in the LGBTQIA community, I am discriminated against mostly just because of the demographic that I live within, and that how different that would be if I lived in an area that was not so like predominantly white, heterosexual, and Mormon. And so that it was just a statement mostly that that is just by living where I live, I am inadvertently discriminated against. That's all I was saying.
That is a great point, Liza. In fact, many of my students share with me that they think it's sort of a systemic discriminatory act if all students are being asked to be placed in certain placements simply because it's in our catchment area. If they know that placement is in a small rural area, particularly with, a community that finds it difficult to work with them. So yes, if you're in an Amish or Mennonite area and it's difficult for them to get their head around that, it would be very difficult for that student to learn, because you're learning under duress.
Yeah, exactly. That was kind of my point. And I mean, this is very personal, but it has been stressful to me, undue stressfully. That doesn't make sense, but I have experienced undue stress because as a student, I want to learn, obviously, so much and from a variety of different midwives, but I feel like it's really, my numbers, my options are really limited as to who I would feel comfortable training under and who would actually feel comfortable training me. And that has caused a lot of stress in my life because I'm just there to learn, and my sexual orientation has nothing to do with my learning and my education for me, but that isn't the case for a lot of the midwives in my area. So that has limited my numbers and my possibilities of people to learn from. And it has been a really disheartening experience for me.
Eliza, thank you so much for sharing. I know it's hard to talk about that on the, or maybe it's not hard, but it certainly can't be a comfortable situation that many students face, as Karline has mentioned. So I do want to give her a chance to kind of talk about how she thinks we can work with preceptors to help.
Definitely, definitely. And we are going to, one of the scenarios talks a little bit about that, because we as tutors and preceptors are supposed to be able to teach anyone and everyone. And if it means that we have to do some homework, the onus is on us. It should not be on the student. And I remember what it was like for me to be a student of color, and then also to be a foreign student. And basically this, neoliberalism that we all are exposed to in this 21st century of pull yourself up by your own bootstraps. But what if you don't have boots? What if you don't have straps? And yes, the other interesting thing that you brought up too is what I'm going to be discussing as well. So I'm so glad, because it's a good segue to that. That not only are we being taught by our preceptors, but we are being taught by our clients. And in fact, the contract that the client is making with us is promising to be not just a participant, but actually an active teacher in our learning. So for instance, when we have students learning how to do pap smears, having the client give them feedback about, yes, you're at the right angle, no, you're at the wrong angle, or yes, you did a really good job, you were very efficient, or you could change the way you were doing things when you were getting ready to start my IV. So if there's a barrier there, and I'm going to be talking about what can students do to help facilitate that. It's not all on the client, it's not all on the tutor, it's the three, the preceptor, student, and client working together as a team. But someone has to be a catalyst. And it's really our responsibilities as educator to be the expert in the room and to be the catalyst and facilitator, despite the surprise, or despite the mistakes, or despite the embarrassment. We cannot pretend we are something that we are not. All we can do is face it. And when we observe ourselves and self-reflect and say, wow, I need to do better, I need to be better. And then actually you're giving an opportunity for everyone around you to learn. So don't discount the value of you being there in that community. And it is hard work. It is very hard work, and you are courageous for just persevering. So we'll definitely get to talk more about that later. Anybody else who has some things that they would like to bring up or questions? I still don't know how to share part of my desktop. I think because I'm in the mode where it's full screen. Maybe that's why. Okay. I guess it's all or nothing. That's okay.
Well,
Go right ahead.
it's Kristen again. If you, oh, there we go. That's great, because then people can actually see the example.
Yeah, I think it has to be just the full screen to be able to see. Yeah, that's okay. I will just trust I'm in a safe space. I don't hear any tornado in the background, so I think it's okay. All right. So the first one is, in this scenario, you have a student whose first language is Spanish. He has met the university admission requirements for English language proficiency. You find yourself feeling increasingly uncomfortable to have him work with clients because you worry if they are having difficulty understanding him during their appointments. You are unsure that you can assign a satisfactory grade for the placement, since communication is such an integral part of the counseling work that you do. So these are the thoughts, of course, of the preceptor. If you can put yourself in the shoes of a preceptor, if you're a student, if you are a preceptor practicing midwife, put yourself in that shoe. Also, if you've ever had the opportunity of being a pregnant individual, being cared for by someone who you're not quite sure of their skills, and language might have been a challenge, or you notice that you have a habit of whenever someone speaks with a thick accent, you make certain assumptions. So there are a number of ways we can look at this. There may be many right answers, and I put that in quotation marks because sometimes there is no right answer. You just do the best that you can. There are many ways of approaching something. We just want to get deep so that it allows us to think. So are there any things that come to the surface here, issues or rights that are being challenged, or isms? I'll start with those questions to begin with. Are there any rights or issues that are being challenged? And I will let you moderate for me, please, since you can see hands and see the chat. Kristen.
Yes, I can see the chat, and it is also possible, I believe, if someone wants to unmute themselves, because that way it can be a bit more interactive if you prefer that at this point, Karline, since we've gotten to the case examples.
Yeah, that would be great. We are having a very interactive discussion here, and I know it's more difficult online, and it's difficult that it's not like Skype where you can see each other's faces, but this is a safe space for us to make mistakes. We're all going to be respecting everybody and not judging anybody. We will be able to ask each other questions such as, I don't understand, what did you mean? Or, you know, I never thought of it that way. Or, what were you thinking when you decided to do that? Can you tell me a little bit more? And, you know, it's a safe space. And if we make a mistake, we will apologize. I'll tell you right now that slide number 5 has a mistake on it, and I apologize because I didn't have time to correct it. But I'll see if you notice the mistake.
So it looks like we have some folks responding. Jenna Dur, both, if you'd like to, I can read what you've written, or if you'd like to unmute yourself. It says the student has a right to learn even if he has a language barrier. He did meet proficiency requirements. It's not the preceptor's job to worry about the communication per se. Also, how can we as midwifery programs and preceptors accommodate cis male midwifery students? Should I pause there? There's a few more.
I think those are all really interesting points. Now, some people would argue that it is the preceptor's job to assess communication because it is one of the competencies, one of the ICM competencies for midwifery. I'm not sure because I had my headphone off for a moment there. It is one of the jobs of the preceptor, some would argue, to assess communication skills because it is one of the ICM midwifery competencies. So it's usually on their checklist or evaluation tool. But it's interesting you should say that because really in this scenario, we don't know if the client has a problem. We just see that the instructor has a problem. Maybe the client has no problem whatsoever and understands perfectly.
Yes, and we have Mickey contributing that I do think it's the preceptor's job to assess communication, so ask the patient to teach back. Amanda also says, I think it's the preceptor's job to be concerned about communication. There is a real barrier which needs to be assessed. It's possible that it's a non-issue for clients. You could argue that the student deserves to receive honest feedback so that he can work on any issues that are present.
If, you know, what do you think are some of the sort of rights? Well, it is a right of the student to receive education, and I certainly agree. Obviously, there's proficiency enough to understand and be able to do well in the program. Sometimes you can do well in the program and do well in a proficiency test and still fail a course, and that's certainly the case with internationally educated midwives that I have taught, who we had to actually talk about medical English rather than just conversational English. And that's the responsibility of the teachers to assess that and to provide supports and other tools. And even the school is supposed to provide extra writing support. They even have courses for someone to learn to speak without an accent for both faculty and for students. But you know, and that's fine, and it's good if the faculty provider provides those resources so that that student can do well in the future and not have anyone discriminate against them, and also be sure of maybe this particular client understands them well, but maybe the next client will not understand them well. So that's important, and we certainly strive for that. But any other concerns that people have?
Yeah, there's a lot coming in. Someone wrote, it's important for all to understand that accent is different than comprehension. However, in our client interactions, we know how important communication is. So if I was the preceptor, I'd want to ensure that the client has opportunity to ask for clarification if she is not understanding what the student said.
That's a great note. Also, you know, do you find that sometimes when somebody is discriminating, they may not even realize it, but they automatically assume that if somebody is disabled, is hearing disabled, or if they're visually disabled, or if they speak with an accent, that it automatically means that they have a lower IQ, that somehow they're cognitively impaired and they end up speaking loudly, or you know, often maybe they need to speak a little bit more slowly, but not necessarily louder to someone who speaks with English as their additional language. This person may have 3 or 4 languages. English is just one of many. So yes, I agree. You have to do a better assessment. And this, do you think that this instructor or this preceptor has waited too long? I mean, how long have they waited, and how many clients have they observed being taken care of before they even broach the subject? This is almost the end of the semester, and they are thinking of failing the student. Anything wrong with that?
Yeah, there's a lot of comments coming in, not necessarily specifically to that question you just asked right then. But we've got that ESL is tough. The test is only written, I believe, and you can let a student get all the way to clinical without having to say much in English, but they need to be able to communicate in English orally as well. And it is the preceptor who assesses that, but we can't let a student get all the way to clinicals before we decide their English is inadequate. This is a problem with the system, and the preceptor and the student have been caught in the middle of it. And we have another comment asking about charting as well, that sometimes preceptors report challenges with charting. And she is curious whose responsibility that is if the charting is an issue as well. So feel free, Karline, if you want to jump in.
So
There's
it
a lot
seems
more
as though
here,
a lot of people are saying there needs to be a lot more assessment and individualization here. So it seems as though need to ask a lot more questions. Individualize your teaching, and even provide resources as needed. And maybe opening the conversation for someone who it's difficult is, I am concerned about, you know, ask the client if there was a problem. They will help with the assessment and evaluation of the student. So all of those things can be, we can have some assistance from the client as well. Other questions or comments?
One from Christy Red Young. In the midwifery model of care, she says, we value client-focused care. So this can create a bias and be embraced with righteous indignation because the client needs are put first and foremost. I wonder if you want to talk about that a little bit, Karline, and how you deal with that as a school. Mickey sort of echoes that as well. Mickey Gilmore saying that it's the right of the preceptor to safeguard their patients.
And so you're balancing care of the client with the needs of the student, and that is difficult, even on the best day, with someone who English is their first language. And the predominant English, not necessarily all of the colloquialisms and the dialects of English. It is challenging, but I think, you know, some of the best strategies I've heard so far is, you know, getting more information, once again, finding out, is it just me that's really biased? And I notice that my back goes up whenever I hear an accent, and the accent actually is not really preventing communication to occur. The client and most people can understand them very well. And maybe I'm the one who has the problem as a midwife. Or if there is a problem, if you anticipate that it could prevent success in the future, starting to get resources to the student early enough so that this client's care and other clients' care doesn't suffer. Because yes, it is client-centered care. At the end of the day, many students say that what attracted them to midwifery was this very holistic care, the extra time that we spend, how patient we are, how nice we are. And then they're sort of shocked when they get into the clinical placement and realize that they are less important and that the focus is not all on them, but it has to be on the client. It does have to be on the client by necessity. And one of the lessons learned is learning how to be humble. In fact, the students need to learn humility and prioritization, and the whole world doesn't revolve around them. A preceptor learns, you know, to work across difference. So as a preceptor who might not be used to speaking with someone who has a deep accent, the preceptor has some learning to do to get used to this student's personality, their accent, where they're coming from, how much time they have, how do they learn best. Maybe they would like to listen to some, you know, videos. Maybe they would like to do some practice of role playing. So on the way to a birth, maybe we're practicing in the car. How would I give, you know, an informed consent with someone? And English is my second language, so I'm going to practice how to do an informed consent to talk about, do I want to do group beta strep testing? And that's something I practice with my preceptor. And I know that over time, my accent is going to get easier to understand, and I'll be able to find those words a lot faster. And so my clients will benefit. So I'll use every opportunity to role play. Do any of those things sound like ideas that you might want to try or even have tried? Have they been helpful? Has anyone worked with someone like this and has any tips or pearls for us of how to balance the needs, address the client, address the needs of the student?
Again, we have a lot going on in the chat, so it's a little hard to have the kind of two conversations going on at once. Why don't I have Jackson? He's had some great comments. Do you want to unmute yourself so we can have a bit of a dialogue?
Sure. Can you guys hear me?
Yes, I can.
Okay. I was just concerned that the assumption that the preceptor's discomfort actually relates to any kind of impact on client care or the client's experience. What I've seen is that a lot of the time preceptors let their own bias get in the way of whether or not students actually succeed in clinical experiences. And my concern is that failing the student contributes to creating more barriers in whatever community that student is from. I guess in this situation, it's a Spanish-speaking community. And that community does have limited access to midwifery care, especially with native Spanish speakers. And so if the student has good midwifery comprehension and skills, I think they deserve to be supported in becoming a midwife and not be held back just because of an accent, which my understanding about how accents develop is like people can work their whole lifetime on trying to change their accent, but if they didn't learn certain muscle skills as a small child, sometimes it's just not available to them to speak differently. And so that person might go on to serve people from their Spanish-speaking community far better than their preceptors who are training them. That was what I said.
That's an excellent point. And the fact that phonetics and the ways that we pronounce certain vowels and consonants is a learned behavior in early childhood. And someone could have 3 PhDs and still speak with a thick accent. And that doesn't, mean that they don't have value. So those are excellent points. Thank you, Jackson.
Yes, thank you for sharing. And it brings up another comment that's come up in the chat, wondering about some ways to deal with this on a systems level in terms of helping our preceptors, if that's something that needs to happen. I don't know if you can speak to that, Karline, if you have.
One of the things that we have in some of our urban centers, and I think what we need to start doing, it's unfortunate that we don't have these at our fingertips, but we have to start digging, looking up those YouTube videos, looking up those TED lectures online to give to our students who want to practice and who have English as an alternative language. Learning, if the university they go to has a program for someone who is learning how to decrease their accent. So they are specialists, they are linguists and maybe speech pathologists. They know how to change the tongue so that it makes the kind of sounds that we use in English. And it may never be exactly like my accent or your accent, but it will be enough. And many people who are faculty or they are paid professional speakers, they actually use these kind of services and they are very effective. So I think that helps, but it also helps in terms of the preceptor learning how to just put aside their bias, recognize that it's there, decide that it is unacceptable to themselves, and decide to start doing individualized teaching, not making assumptions, not assuming that the student doesn't know their stuff. They may know their stuff very well, they might not be able to communicate it as well, but doing a deeper assessment. Now, someone may say that takes a lot more time and energy. Yes, it does. It does. And it's worth it. If this provider is going to be a strong provider who provides care to anyone and everyone, but in particular is not so disheartened that they continue and then later on go on to provide care in their community, they are going to be so valuable. We don't want to discourage them and cause them to drop out of midwifery too soon. We need this provider. So shall I go on to the next scenario now? Which I'm not sure how to do.
Well, okay. I can sort of bring in some more of the comments while you're trying to do that. And okay. I know it's a lot to ask with the multitasking. I think you should be able to sort of hit the right arrow button.
There we go. I have to get rid of this thing here. Oh my goodness. How do I get rid of this? Oh boy.
I'm not sure about that
annotation thing. Oh boy.
It's hard to practice everything in advance, isn't it, Karline?
Practice everything. Clear all drawing. There we go. Okay.
Why don't you go ahead and go back a few slides? Yeah, with the left arrow.
I will do that. Previous. We're learning on the job. Good. Okay.
Shall I bring in a few just to try to summarize some of the other comments? And
yes, great.
I believe some of them apply across more than one scenario. Just that in that particular first scenario, there was no indication from the scenario that there was an actual problem of communication, just the preceptor's worry that it theoretically could be a problem. And so, someone said asking the client in private without the student present could be a possibility. And then Mickey Gilmore noted that for any level of difference, their preceptors, for example, would not accept a male midwifery student when in fact the patients didn't care. And so bringing that up, and yet that is counterbalanced with Christy Red Young's comment that they've had, students report that preceptors have told the students they need to change their hairstyle because the clients would be uncomfortable. So I think that's just a broad, something we want to try to address here. If we can, how do we work on a systems level with some of these preceptors who perceive that there's a problem when there may not even be
That's
an
a
actual
very
problem.
good point. We have nursing staff that sometimes will say to our student, what you're wearing is not very professional. And that student might be poor. That's all they can afford. It's clean. It is professional. Maybe there's certain taboos of not wearing jeans. In our settings, we do not wear lab coats. We don't wear scrubs. After they, are in practice for themselves, various midwives have decided whether just for the birth, if they anticipate a lot of splashes, they'll maybe put something over their clothing. But for the most part, our model sort of wants to decrease that power differential. So you're seeing people in street clothes that are being careful about infection control, but they're in their street clothes. And, we'll have students who are very upset about saying they don't want me to be me. This is me. My clothing is who I am. And certainly if somebody is being asked to change their hairstyle, unless it was really off-putting, I don't think that's a human rights violation. That's all I can say. If they wear a Habib, or if they have purple hair, or if they have a nose ring, that is part of who they are. And we're not allowed, our human rights will not allow us to dictate that. Now, if a school decides that they will have a code, a dress code, or a hospital has a certain dress code, sometimes we cannot change those codes, even though our program believes differently. And if it's a means to an end, I guess we have to try to decide, is that the hill you're going to die on? Or are you going to make it a means to an end? It's just a strategy. We change for a moment. It's not changing who you are inside. You're not taking anything away. You are only adding. And I tell many students, yes, you are an actress or an actor for the next few months. It's an act. It's like when you put on your poker face during a shoulder dystocia and inside you're peeing your pants, but nobody knows it because you're smiling, you're giving instructions that are assertive, directive. And afterwards, when they replay the video that they shouldn't have been replaying for risk management reasons, you realized, oh, Karline, was that a shoulder dystocia? Because you were so calm during that. Yes, we decide we're going to put on an act because we're not the star of the show. The client is the star of the show. So similarly, you have your goal on the prize. The prize is to graduate. After you graduate, you're going to set up your midwifery clinic very differently. You're going to set up your birth center very differently. But for now, you need to get through this placement. And the goal is to be a midwife who provides equitable care to a great number of people. If you fail the program, you're not providing midwifery care to anybody. So it's a way of thinking. It may not suit everybody, but it's one of the things that I think has helped many of my students who have felt oppression and discrimination get through. And having a mentorship program where there's someone who you feel safe with, you can cry on their shoulder. You can't tell your family all of this because some of it, is not appropriate to tell them. If there was a shoulder dystocia or something like that, how the obstetrician yelled at you or how the nurses said something that was inappropriate. But you can, because we don't want them to completely lose faith in the healthcare system. One day they will be a care recipient, and we don't want to take all of the dirty laundry out for everyone to see, but certainly another midwife, another midwifery student, someone you trust. And you need those 5 friends who are going to keep you sane for the rest of your life. The person who's your energizer, who's your, unconditional love, the person who jokes around with you, the person who brings you something to eat, the person who reminds you that you forgot to take out something or pay a bill, and they're the ones who organize you and very directive. But you need those friends as your network of support, for sure. Scenario 2, you're caring for Daisy, a 47-year-old Cherokee woman who's arrived for her community nutrition screening day, or who presents for her annual GYN exam or whatever you may like it to be. And the student begins by taking a history. The client describes her challenges with respect to eating well due to her limited disability benefits. Macaroni, hot dogs, and Jell-O are her favorite foods. You observe that the student does not address ethnicity as a risk factor in describing health risks for diabetes. Neither does she address the creative ways that Daisy has developed for coping with a limited budget. So any issues that are emerging, any possible discrimination that is happening, that's at play, and how might you address the student if you were the preceptor?
We'll probably have to give folks a chance to.
And I'll go ahead and give you the next hint. Because the student explains, you decide you're going to go ahead and discuss it right after the visit and not wait. You decided, you know, you better talk about it as you're leaving that visit. And you asked her, why did she do what she did? And she said she was afraid of unfairly stereotyping Aboriginal or Native Indian people. And she wanted to show respect for Daisy's individuality. So that's why she didn't even at all bring up the fact of anything to do with Native Indian culture.
We're not having anything come in the chat in this moment. There's still sort of some unaddressed issues from the last one. But is there anyone who wants to?
Karline, this is Audrey. Can I
Please go ahead, Audrey.
thought? So what's not clear to me here is whether it's the preceptor or the student who is kind of, I was going to say at fault here. Like it could well be that the student is trying to address Daisy as an individual and not putting her in a box and saying, you know, like she's trying to look at specifically what Daisy could be doing differently, sort of looking at her own individual diet, as opposed to talking with her about the risks for, you know, an Aboriginal community for diabetes, right? But it's also possible that the student was avoiding having that conversation, and the preceptors, you know, has an opportunity here to say something to the student about, you know, specifically addressing the needs of a woman in an Aboriginal community where there are high risk, you know, it is a high risk community for diabetes. So I'm a little sort of unclear about which is really at play here.
Well, I think you gave an amazing response, because it could be both or one or none. Let's pretend it was the last one, the latter, that really the preceptor might even want to role play and say, it sounds as though you're having some difficulty understanding how to be culturally sensitive. And I have the same challenges too. Sometimes I don't even know if a person wants to identify as Native, or if they're very proud of their culture and their heritage, and they would even be encouraged if I bring up even my lame attempts to try to address that. So there are clients that I have, for example, that I ask the question of, what is your heritage? Why? Because it makes me know what we can talk about during the labor or the birth or during your visits, or we can share recipes or talk about food, or I can try to ask you if there are any special cultural preferences that you would like that I can honor. And I've had some Native or Aboriginal peoples tell me, no, not really. You know, I live in the city. I don't live on the reserve. And, you know, no, I don't even know how to do A, B, or C. You know, I'm pretty much Canadian. And then others who embrace and look for every opportunity to share with me cultural health beliefs, or beliefs around birth, or could we smudge, or could my elder come, or could we do this and this and this, or I heard about the birth center that it's based on, you know, Aboriginal themes, and I'd really like to have my birth there, because then we could really have the whole family, and it could be very, very family centered, and our community would be encouraged. So I just ask them, I say, how much would you want, if any, of your Aboriginal background or your heritage, or the way that you remembered doing things with your parents, to be involved in your care? When I went to the far north to work with the Inuit in northern Quebec, we talked about those kind of things. Like, okay, so we need more iron. What are the things that you would enjoy eating that have more iron that you could afford? And in that community, you know, they would have a lot of salmon and a lot of fish, sometimes, you know, raw or dried. And we talked about how, oh, that's great, because that's really going to help you if you do happen to have a postpartum hemorrhage. You know, that's going to really put you in good stead. And, you know, especially if you're a smoker, you know, despite the smoking, you know, having all of this iron in your diet with the beef jerky kind of thing, they use caribou jerky, and you know, that's going to help. So we don't know if Daisy, living in her urban setting, is going to have the money for that or the desire for those kind of things, but we can work with what she has. But not to even bring it up, like to be afraid to even bring it up and even broach the question, means either she doesn't know or she doesn't realize how important it is to demonstrate cultural sensitivity to her preceptor. And sometimes in those situations, we have to do the modeling for the student, and so they learn from us, because it's learned behavior. You can't always learn it from a book.
Right, and perhaps avoiding, and well, and not perhaps, and avoiding the conversation completely, in fact, puts this client at risk, right? So yeah, I really appreciate that response, Karline. Thanks.
Yeah, so it's okay for the preceptor to jump in and do some of that visit and interact with the client. She doesn't have to, or he doesn't have to hesitate in that situation.
And then
Any
we
other
have,
comments?
yeah, we have one from Amanda. In my experience working as a white person outsider in a tribal community, diabetes can be such a sensitive subject that needs to be discussed with a lot of care. I don't have any perfect answers, just that it is important to explore how the client feels about it before proceeding with counseling. And then Wendy responded that given that there is no biological basis for race, I would be interested in addressing the underlying structural factors that may put Daisy at higher risk for diabetes. Certainly any nutritional counseling should take into account each client's cultural norms, which they get to define, not us. But this client's Cherokee heritage is not in itself the risk factor. How she is treated in a racist colonizer society is.
Bravo, I would agree with you. Some of the emerging research, though, is telling us that there's some resilience factors as well as some risk factors that are actually based upon race and physiology, based on epigenetics. And it's emerging cutting edge research. The story's not over yet. I think we're very holistic beings. We have a mind, a body, a soul, a spirit, and that all of those things are affected by, you know, our post-colonial world. All of us worldwide are affected. Makes sense, you know, the stress that we see in our lives, and if it's generational stress and it's, you know, there's sort of an echo of it in our lives, even in generations to come. But certainly finding out which grocery stores she goes to on her way to her appointments, finding out which days the bus runs and which store she could get some fresh fruits and vegetables from, finding out the things that she really likes and how do we get them and how do we make a diabetic version of them. So, you know, recipe day, cooking, it could be actually a very fun visit, not a judgmental visit. So it really does mean think outside of the box, be creative for sure. And let her know that you're not judging her. You know, and that's an art for sure. I'm afraid we're running a little bit behind, so I want to make sure we don't run out of time. Number 3, birth center. You're preparing for the first childbirth class in your birth center when a client and her same-sex partner arrives. They're expecting a baby in 12 weeks, affectionately arm in arm. They're animatedly discussing the best car seat to purchase. They approach your student and ask for her expert opinion. Your student, who is Orthodox Jewish, appears to be taken off guard, begins to stutter and gives no eye contact to the expectant mothers. You are fuming because the student is low in birth numbers and you don't want her to once again lose another opportunity. However, it seems awkward and you're unsure how to salvage the situation. What are the presenting issues, rights that are being challenged? How might you address the student? How can the preceptor balance the needs of the student and the consumer or client?
To me, I would have a hard, this is Jackson, I'd have a hard time being concerned about the birth numbers when she's actively not not even able to meet eye to eye with these people. Like, if you can't look somebody in the eye, I don't think it's appropriate for you to be at their birth.
Definitely, there are some barriers there. What do you think those barriers are caused by? What causes our students to freeze? Any ideas? Differential diagnoses.
Some of what's coming in, someone had the question, does the student drive? Are we making an assumption about her? Fear? It is interesting that many cultures do not meet eye to eye. Orthodox or Hasidic in particular often do not meet eye to eye.
I guess
in many African cultures as well, you always look down to show respect if you're from the African diaspora, and we're taught that from childhood. So looking eye to eye might not mean that you're being rude, but you're showing respect. That's a good point. We don't know if she's a driver. We don't know if she's afraid because she doesn't know which car seat is the right car seat. And she's from a family where you are punished for being wrong or giving the wrong answer. Or it could be she's never worked with, a gay couple before and doesn't want to make a mistake, so she freezes, just like she was freeze for shoulder dystocia. Or it could mean that she has been taught that this is evil and somehow she'll drop down and die if she works with this client. And that it's just it causes so much social dissonance. She didn't even think about it before, just as maybe the Catholic student didn't think about the fact that she'd have to be teaching about contraceptive choices. And her particular priest says that, they don't use contraception. Is teaching about contraception against her religion? Does it mean she's promoting contraception? When the Orthodox Muslim student who is fully covered comes to the door to greet the client for a postpartum home visit, what should they do to work across difference so that it doesn't interfere when the husband or partner comes to the door and wants to shake her hand and it's a male partner? Does she recoil in horror, or does she smile very welcomingly and say, I'm so glad to see you. Just want to let you know that if you notice I'm not shaking your hand, it's not because I think you have the cooties or something, but I'm not allowed in my Orthodox Muslim, religion to shake the hand of any man who isn't my son, my brother, or my husband. I'm so sorry, but I'm so glad to see you, and I hear the baby is eating lots. So any suggestions that you can give me, pearls, of when you're working with a student who freezes? What do you do? How do you handle that situation and still redeem that situation and not lose these clients?
Yeah, I think you're really bringing up a lot for people, Karline, working, and really working out how to work across difference is huge. I do want to let you know that there's something going on in the chat that I know you can't see. Just that one person mentioned feeling triggered by the descriptor that the student is an Orthodox Jew. Are we assuming that an Orthodox Jew can't treat a client sensitively? Someone else said, is there a relevance to the student being Orthodox Jewish in this scenario? And someone saying that relevance is that many Orthodox persons have maybe not been exposed. And so the religious background is very relevant. Someone is saying, Nikki is saying, it's where she comes from and the perception of where she stands is colored by her religion. And so there's a little more
These
here.
are all great points. I'm so glad that we're recording this so I can look at it afterwards as well. Those are all very valid points. Now, sometimes when I gave all those scenarios that I shared, a student doesn't realize that their job as a midwife will entail this. They just automatically assume that they're going to be working in their own community when they graduate. And in fact, that was the reason they came into midwifery, to provide a service in the community. Might have a student who is Mennonite or you know, and I had to think of myself, you know, going into, coming from a very strong faith background, going into a situation where I was asked to participate in a termination of pregnancy, and the challenge of that, and being told, you know, this is your job in labor and delivery, and you cannot abandon the patient, and then no one listening to me as I horrified realized that this was not a 20-weeker, this was a 32-weeker. And what have I walked into on my shift? And how do I advocate for this woman who wants something for pain and who's just learned all these things, all these diagnoses, and was told, well, you better terminate, you know, and having to deal with that. So working across different belief systems, working across different dress, working across different exposure. So I may, as a preceptor, come across something I've never seen before. The student may come across something they've never seen before. It's outside of their experience. But how do we approach it as a preceptor? Do we take over and role model? Many of us were thinking maybe that would be the thing to do. Just take over from the student, you know, sort of embrace the situation and decide to be a role model and just model the behavior, the statements, you know, be apologetic to the couple who are being, obviously their feelings are being hurt. They don't know what's going on. It's times like that that sometimes humor works, sometimes it doesn't, but just being gracious and salvaging the situation, and then definitely debriefing with the student afterwards and asking all those questions. Was it because you've never seen this? Didn't know how to talk about it? What was there a deficit in? Was there a deficit in you didn't know which car seat to suggest and you felt embarrassed about that? Was there a deficit in, you know, not having had the experience of even knowing about same-sex couples before? How can I help you with that? Because we have a lot of couples who you're going to be serving in this community, and we don't have a choice. We serve everyone. Everyone has universal access. Do we need to go through some role playing and practice talking? And do we need to talk about some of your fears? What are your fears, if there are any? And don't make any assumptions why she froze at that moment. So the preceptor has to be respectful to the rights and the needs of the student, and has to be aware, certainly people have mentioned that already, of their own bias. So that preceptor has to be aware of their own bias about the group that that student represents as well. I'm mindful of the time that we only have 1 minute, and I'm sorry. Making mistakes and trying to be respectful. You've been assigned a student for a placement in your birth center in a small town. She will be meeting her first client for the day. Tally is a trans male who arrives with their male partner, Terry. They have many questions about recovery from the pregnancy, infant feeding, and the role of midwives, should they require a transfer of care to the hospital for complications in labor. The student has never worked with a trans client before and eager not to make any mistakes. She asks what Tally's plans are for breastfeeding the baby. Tally's facial expression displays their discomfort, and they roll their eyes. That's exactly what I mean. We'd prefer if you use the term chest feeding with us. I'm wondering if you can even really help us, because, you know, we want to keep my chest from swelling, and if all that surgery I've done could be affected and it affects my appearance afterwards, you know, should I even chest feed? You know what, I'm even wondering if the midwife knows how to look after me, because this interaction with you tells me that maybe I should have seen a physician for my care instead of a midwife. So what are the issues that are presenting? How might you address this with the student? How might you respond to Tally? Is it better or more respectful not to even try to be transsensitive and possibly fail? Or is it better to just try, apologize, and keep trying to get better at each interaction? What could help this couple in the future for future visits?
So Karline, I do want to give people a chance to respond here. I also wonder, and I don't want to put you in the spot so you don't have to answer this minute, but because you have so much rich material that's getting just so many comments in the chat section, and I kind of wonder if the call that we have scheduled in January on the 19th might be a better chance for us to keep working with these scenarios, because they're so rich, and there's so much we could unpack and think about the different ways to address the concerns of the student, of the preceptor, of the schools. It doesn't have to be that day in particular if you're unavailable, but I wonder about another session to work a little bit through these. Also, we can allow people to unmute themselves a little more easily as well in that scenario.
That is a fantastic idea, because I am learning from all of you as well. I really value you sharing some of the points that I need to bring up in future discussions, things that I need to make more clear as I'm delivering the scenario while I'm still trying to be succinct. And so I would be happy to come back again.
Okay, well, why don't I work with you on that, Karline, and I'll inform everyone through the usual way, which if you're on the MailChimp list, great, that's the way that it will happen, and also through the website, equitymidwifery.org. Courtney has so graciously also put some information in the chat for everyone so that they can find out more information for the future. I think that might be the best way, because it really is rich, and I'm so grateful to you for your time. And I do want to make sure that people are able to evaluate this webinar if they want to. There's a Survey Monkey that is in the chat box for folks. I can share that with Karline as well, and that will help inform the next time that we meet together. Also, I'll be sending out an email through the MailChimp, so sometimes you have to kind of look for it in your junk mail or your promotions section, but I will send it out that way as well. And you're welcome to email me with any questions or comments as well. If you want to stop sharing your screen, Karline, I'll go ahead and just share mine for a moment to let people see that. And I will, yes, Christy is saying, I bet Karline would love to have access to a copy of this chat log after, and I believe you are right, and that all comes through Zoom, and I will definitely get that to her. We're having lots of thank you for the rich information. And Karline, yes, is noting, yes, that was the slide with the errors. We discovered it. So I greatly appreciate you all tuning in, and it sounds like we've got lots more to talk about in the future. Thank you so much, Karline, for your time. And I'll just go ahead and share the, if I can find it here. The website where you can find more information is equitymidwifery.org. And under Connect is where you can find out about if we end up doing it as a call. But as I said, I'll be sending out the email as well. Thank you, everyone, so much. I want to be respectful of the time that we are ending today, but very rich and more to be had. So again, thank you so much.